And this is the pathway to register in a specialty division. If you are not you are not coming from UAE, from European Union, they have different completely pathway. Is called category E, and as I said, portfolio based applications. And this is what they are doing. Actually, you should demonstrate your knowledge, your skills, and your experience. Okay, this is actually what they mean from you, and collection of whole your papers, what you did during your training in occupational medicine, and CBDs, publishing, you are giving lectures. What you did, you should collect it. Yani. This is advice from now. If you did anything, you should keep it with you. If you're thinking at the end you want to register in any of this register specialty division in Europe. And I think this
Muhammad.
is all has been very cited. Yes.
Thank you very much, Muhammad. I think the important, the different paths between Muhammad and Mu'tasim to the specialty. I think the only difference is Muhammad was one of an extremely lucky group who enrolled in the University of Manchester MSc course, which was delivered completely here in the Middle East.
Yes,
This was
it was a blended courses.
it was yeah it was a blended learning course. And as Muhammad has just mentioned, I think things are much better now. I think days, not many people were talking about occupational health. I don't think the roots to a specialty or even to knowledge are not as as obvious or as available as today. So these guys joined the MSc degree in occupational health, which I think has done them an absolutely great, great, you know, push in their career. Um, I think between 2014 and 2016, almost 32 doctors from the Middle East went through the Manchester course. You don't have to go through that. I don't think it's not. This is not
Yeah,
a
Omar,
visit now. Yes.
just want to add something. The people they think that is all shifting to occupational health because they have no choice. No, it's not like that at all. The occupational health, it is multifaceted. They have big, wide range of thinking. They are very interesting, amazing. It's not because I have no choice. I have so many choices when I choose the occupational health to do. Yes, I have first part of the surgery. I have second part of the ER, and I didn't do it. I just gone to occupational health because it is sad time. It seemed to be it's very interesting. It's unchallenging.
Thank you very much, Muhammad. I think we will probably come back to you for more clarifications and more speech on more talk on your speech.
Okay, thank you.
Is Inas with us? Khadir, can you see Inas? It's about 8 o'clock in the morning for Inas. I think she texted me quite early. Inas lives in California, so the time difference is yeah. So we probably introduce, and Aisha is also not here, but I think I'll probably start with Dr. Aisha's slides. So can you put Dr. Aisha's slides for me, please? Let me see if I've got. Let me just. Right. Well, thank you very much. I think I'm going to present Dr. Aisha's slides as she is, she is still driving. She will probably come and join us a little bit later. Dr. Aisha Hashim, I'll tell you another story. In 2010, once we established the occupational health department in Adnuk, um, Muhammad, and some other colleagues were helping. I was going home one day towards the end of the day, and on the corridor out of the department, I met this very young doctor in a white coat and a stethoscope around her shoulders. And we were walking together towards the, towards the elevators. So I introduced myself, and she said, "Yes, yes, I came to see you earlier. My name is Dr. Ali. I've just joined ADNOC as an occupational, as a family physician, and I came to see you earlier, and we haven't, we missed each other's. So,
She's here.
oh, is Aisha here now? Excellent. So Dr. Aisha is here. I'll continue with my introduction and let her, and if you give her, the co-host. So I'll just talk about the assistant driller tale. In my clinic one day, excellent. In my clinic one day, I saw an individual for his routine health surveillance. He worked for a company called the National Drilling Company, which was, it's still part of ADNOC Group. And I asked him, what is his job? He told me he is an assistant driller. I asked him, for how long have you been doing the job? He said he has been doing the job for 27 years. So I asked him, have you been an assistant driller for 27 years? Or were you, in another position and then you moved into an assistant driller? And he laughed and he said to me, no, you come to the Middle East as an assistant driller, you remain as an assistant driller. So if the driller you are assisting leaves the job for any reason, they will not promote you to a driller. They will hire a driller. So you will remain an assistant driller. I used to tell this to my children, when they wanted to come to work in the Middle East, and I said to them, I would suggest you wait until you are a driller and then come to the Middle East. The discussions we had then was occupational medicine has actually changed this for so many doctors there. You come as a GP, you stay and work as a GP for forever. Occupational health has opened, the door for people to move from assistant driller to a driller. We have talked about this quite a bit, and I suggested this as a title for Aisha's talk, because her experience is in the Middle East. I can tell you frankly, I have met so many occupational physicians in my career. I have not known anyone whose occupational medicine has changed their career as Dr. Aisha. Dr. Aisha, from that very young, rather shy family physician, is now one of the most senior leaders in the oil and gas industry in Abu Dhabi. going through different roles, and genuinely, she has been good in absolutely every single one of them. Another landmark, Aisha, Landry, you probably remember this. Aisha was or is the fairest member of the Irish Faculty of Occupational Medicine from the UAE. I remember the day vividly when we sat after, the exams in Al Ain, and then Martin stood up and said, guys, we have got our first UAE member of the faculty. And I knew then that was Dr. Aisha. I believe Dr. Aisha is here now. So, Dr. Aisha, the floor is yours.
Yeah, thank you very much. Assalamu alaikum.
Are
Good
you
evening
driving?
from UAE.
Are you still in the...
No, I parked already. No, I parked already. Yeah.
Okay, okay.
Okay. Actually, thank you very much, Dr. Amar, for the introduction. And I really don't want to miss this opportunity. It's really a great pleasure to be part of this webinar with my colleagues, experts in the field of occupational medicine, who are sharing their expertise and specialty journey. And I believe for myself, for Dr. Mohammed Musa, and many of other colleagues in the region, we wouldn't achieve this without your support, Dr. Amar. Let me begin by saying that to my colleagues here who are interested in the field of occupational medicine, that you guys have made the right choice by choosing the specialty of occupational medicine for your career. There is a limited number of occupational physicians worldwide, and with the international growth of the economy, the demand for occupational physicians will continue to increase. Occupational health is a highly distinctive field that requires a holistic approach. The practitioner into the specialty must wear multiple hats, and they do interact not only with patients. You do interact with employees, with employers, with HSE professionals, with human resource representatives, with healthcare providers and specialists from different specialties, in addition to legal representatives. One unique aspect of being an occupational physician, and this is the question that I keep receiving during my training programs for the specialties, that to whom is your duty of care in these specialties? And the answer is that towards both the employer and the employee. The company has recruited you to protect the right of the company while maintaining the health and safety of its employees. Today, moving to the next slide. So today I'd like to share my professional journey with you. I have 20 years of working experience, starting my career as a family physician and deputy manager in one of the primary healthcare clinics in Dubai. This clinic provided primary healthcare services to around 10,000 residents of Masqeim district, including employees and contractors from different risk industries. During this time, I managed a team of over 30 medical and administrative staff for almost 6 years. In mid-2011, I moved to Adnok Medical Center as a family physician. It was during my first few weeks there that I met Dr. Umar Najib, who encouraged me to enroll in the occupational medicine certification and specialize in the field of occupational medicine. So if you can go next slide. So after conducting an extensive review, I realized that the specialty lacked subject matter experts internationally, and there was a huge demand for professionals in this field, especially in UAE. Additionally, there was no UAE national female specialized in this important field to meet the growing industrial demands in our region. So I went back to Dr. Umar and asked him, please tell me more about this specialty and how I should start my journey in occupational medicine. To be honest, to this day, I consider knowing Dr. Umar Najib and becoming a certified occupational health physician as the two best things happened in my career. With Dr. Umar's support, I joined the Manchester Advanced Diploma course, myself, Dr. Mohammed Musa, and many other colleagues, where I can tell you 90%, if not more of them, has already became occupational health, registered occupational health specialists. The main objective of getting into the Manchester course, as highlighted by Dr. Umar, is to build up the required technical knowledge. And I was lucky myself, Dr. Mohammed Musa, and many other colleagues that I was working with Dr. Umar in the same clinic. So he was coaching and mentoring me. So I gained a hands-on experience at the ADNOC Occupational Health Center, mentored and guided by Dr. Umar. I was not alone, actually. There were a group of more than, I think, 25 physicians during that time, and I was fortunate to be one of them. And in addition to that, the support that we received from the Faculty of Occupational Medicine at the Royal College of Physicians Ireland, who were providing us multiple awareness and training sessions throughout the year. So as the head of the unit, I manage occupational health services within ADNOC and its 23 operating companies, where we provided services for more than 150,000 employees working in offshore, remote onshore, and in-town locations, exposed to various hazards such as physical, chemical, biological, and ergonomics. My role involved a mix of hands-on, full-fledged scope of occupational health services and management duties. This includes medical fitness assessment, pre-employment, periodic return to work programs, job functional assessments, disability assessment, and sickness absence management, among others. I want to highlight how fortunate I have been to have Dr. Umar's support throughout this amazing journey. With his guidance, we established the Emirates Society of Occupational Medicine and represented actually the specialty in many local and international occupational medicine platforms. You can see Dr. Umar, do you remember the second photo?
I do.
Where was that?
I do.
I remember it was the ICO in Ireland, and Dr. Umar flight all the way from London to come and support us, the occupational health physician from the Middle East. Okay, moving to the next slide. So I was very much interested in understanding how occupational health functions are governed and how regulations and standards are developed in the oil and gas industry. Once again, with the support of Dr. Umar, I got the opportunity to move to the HSE function, which is directly reporting to the ADNOC Group CEO as the Occupational Health and Environment Department Manager. In this role, I managed the development of strategic policies and corporate guidelines for occupational health, industrial hygiene, sustainability, and environmental management across the ADNOC Group companies and affiliates. I also oversaw the implementation of those standards and guidelines. Additionally, I was providing technical advice on all aspects of those codes of practices and led and participated in internal and external compliance assurance program. As part of the same scope, I was participating and representing UAE and ADNOC in many international and national occupational health strategic initiatives and projects as a subject matter expert in the field. If you can go to the next slide. So in 2019, I was assigned the role of site HSE manager in a field that had both onshore and offshore operations, becoming the first female to handle an HSE manager role in the oil and gas industry in UAE. In this position, I managed and integrated activities and programs related to personnel health, safety, and environmental protection. My responsibilities included ensuring compliance with HSE standards and guidelines to prevent, I would say, injuries and harm to the environment. I also led the HSE inspections and audits and monitored the incident investigations and the implementations of the recommendation. Furthermore, I was responsible for monitoring site HSE emergency response preparedness and relevant contingency plans. Recently, I have moved to ADNOC Gas as a VP Sustainability and ESG function. I'm passionate about driving a positive change through sustainable business practices. I believe you agree with me that in today's world, the importance of sustainable practices cannot be overstated. We have a unique opportunity to make a difference by incorporating sustainability into our operations and businesses. By doing so, we are not only mitigating the environmental impact, but also contributing to the health and well-being of our employee. I believe that occupational health plays a vital role in the success of businesses and the overall wellness of our employee. So just to conclude, The specialty of occupational health has provided me with great opportunities throughout my 20 years work journey. It opens multiple doors at different levels, as highlighted by Dr. Amr Najib. Based on this journey, I have been also selected as a board member in the National Marine Dredging Company here in UAE, one of the biggest dredging company in the Middle East. And again, I just want to say that you guys are on the right track. And I'm confident that with the support of Dr. Umar and the team, we are all here to support you. You will acquire the necessary knowledge, skills, and certification to become a competent occupational health physician. What we have gone through in 2011, I think in these 12 or 13 years, the resources are there. The technical expertise and the number of certified occupational health physician has increased. I think I remember in 2011 there were around Dr. Amar was the only occupational medicine consultant at that time, and now we have I think around 5 or 6 in addition to more than 10 or 15 occupational health physicians here in UAE. So I think it's the right track, and I think we are here to support you and we'll provide you with the required resources, along with the support, of course, of the Royal College and the colleagues here. I'm very happy and glad to see you, Dr. Amar, Dr. Mohammed Musa, Dr. Mu'tasam, because, and Dr. Mohammed, you look much younger, huh?
How you
So
are?
this is the
Okay,
environment
thank you.
in Ireland, it seems.
Thank you. Thank you, Dr. Aisha.
Thank you so much, Dr. Aisha. Thank you so much. Aisha is very modest. She said it very quietly that she's moved to become the VP of of the sustainability department. VP stands for Vice President. So as I said earlier, you can just look at that journey from that young shy girl to a vice president in one of the largest oil and gas companies in the world. And absolutely, Aisha is quite right. She kept saying it's all because of me. It was basically because I was the only one. So it really, there's absolutely no choice.
Just let me to tell them something, yani, Dr. Omar. We are starting the work at 7 o'clock. You are preparing us to come at 6 morning to attend your lectures. Me and Dr. Aisha alone.
And Dr. Mohammed, and leave at 7. You remember?
And leave at 7,
yes.
And again, we have the weekend sessions, sitting in coffee shops,
yes, in weekend,
gathering.
yes.
And thank you very much.
Thank you.
I'm speechless, Dr. Amar Salaha. This long journey, myself, Dr. Mohammed Musa, and all the occupational health physicians in the Middle East, we owe you a lot.
Thank you so much,
Yes.
guys. You have worked hard, and you absolutely deserve what you have now. And I have absolutely no doubt you're just going to continue and give back. By the way, Dr. Aisha is the regional specialty advisor, so for the Middle East. So guys, those of you who are here in the Middle East, anything regarding the occupational health specialty, yeah, make sure that you've got Dr. Aisha's email address. So that is very important. One other thing, I recall vividly, Aisha, the interview or you did with the faculty after you passed your membership. And I really, if you have that piece of interview, I think is one of the most beautiful pieces I have read in occupational medicine. She was talking about, she always thought of herself as a doctor in a white coat and, the stethoscope and that. And she said, to get up in the morning, to drive to Al Bateen Airport, which is a local airport in Abu Dhabi, hop on a helicopter, see beautiful Abu Dhabi, underneath, and travel to an oil rig. and spend the day there with the workers, seeing how work is being done. I think this is one of the most beautiful pieces. So Aisha, it would be great if you can dig that piece out and share it with us. We'll be happy
I
to
will.
to put it on Kweha website for everyone to see. And thank you very much, Aisha. Aisha's traveled 3 hours. Is it 3 hours? Have you reached home, or are you still not?
Almost there. I just parked aside actually to complete this nice test.
Thank you so much. Thank you so much, Aisha.
Dr. Muhammad, Dr. Amar, I'm not anymore that shy girl. You know that, yeah?
Okay. And
Being,
congratulations, Dr. Aisha.
you know why I'm saying that? Because
Yeah.
I think this occupational health journey has shaped even my personality, by the way. Wearing different hats, dealing with different level employees, from the labor at a remote area camp to CEO, convincing them on how important is occupational health. It really shaped my personality, because being an occupational health, you need to be not only a good doctor, but also a good leader and a good politician. How you communicate a message to the different levels, including management, chief medical officer, different specialists from different specialties, who you need from them a good report with Dr. Amar diagnosis, prognosis, management plan, templates. So it was not an easy journey, but it really shaped my personality as a leader.
Thank you so much, Aisha. And as you would have seen, the diversity of the work and occupational health can do. Right from being the typical doctor sitting, seeing patients and examining them, to actually, getting onto helicopters, to oil rigs, and sitting with the, senior management, relaying messages about health and sustainability, Aisha. And sustainability. I'll have to learn
Yes.
more about this. This is probably too old for that. Thank you so much, Aisha, and save journey.
Thank you very much. Thank you. Thank you.
Safely, and don't be surprised if you are flooded with emails from today.
Now I'm waiting for those emails. I'm ready to help and
Thank you
support
so
myself and the rest of the network here in UAE.
Thank you so much.
Thank you.
And I am absolutely delighted to see Ines is here and awake. In the last few months, I've been traveling between, different countries, and the time zone is a huge problem. I must have confused Ines to no limit. I think Ines believes, we are starting at 10 o'clock Abu Dhabi time. So she thought she could, although she you did text me, earlier. So it must have been very, very early for you. And it is Saturday. Ines, thank you so much for being with us so early in the day, and on your weekend as well. I have known Ines for so many years. You were not here. Mu'tasim was singing your praises when you were asleep, so you must have had good dreams. So I have known Ines before we actually met face to face. We talked about various occupational health issues in the Middle East, in Sudan, and about lots of stuff relating, careers and development and stuff like that. Ines was instrumental during the COVID in organizing one of the really helpful webinars to our colleagues in Sudan. If you would recall that, Ines, I think during COVID, we lost so many doctors in Sudan. And at one time, it wasn't just, the fear and the apprehension. Actually, the healthcare workers physically left the premises. So Ines and other colleagues got in, and that was pushed to the highest level within, the Ministry of Health, the Federal Ministry, and the Ministry of Health in Khartoum. And I must say, when I went to Sudan, so many people came to speak about that, and so many people thought how useful that was. Inas is a consultant occupational physician. She's got a totally different experience to, the three colleagues from around this area. We put the title for her as the experience from the new world. I would probably say minus Otinia. Inas works as the managing director of the university, California University Clinic, and she is also a clinical professor of occupational medicine. Thank you so much, Inas, for being with us so early in the morning.
Assalamu alaikum. Can you guys hear me? Can you hear me
Yes,
okay?
yes.
You can.
Okay, sorry. So first of all, I am really sorry. I think this has just been the mix-up in the time. I was actually awake and I had no reason not to join if I had the hours right. So apologies for this late showing up. I will get into the present. Thank you, Dr. Omar, for the nice introduction. I think I join all the colleagues in extending, just maybe sharing the story of how I got to know you when I found your picture in a website that had all the occupational physician doctors in the Gulf at that time. I think this was probably around 2011 or 2012. And I was curious to find colleagues in outside, just in the whole world, because for some reason, being in occupational medicine sometimes makes you feel you're a very lonely person. Not many people work in the field, at least not many Sudanese or co-workers I've had here in the US. And finding not just any occupational physician, but definitely a leader and a mentor was just a godsend for me. And I think Dr. Omar, you've continued to be that role as my mentor, guiding star everywhere throughout my journey. So thank you for giving me the chance to share that experience and that journey. I'm going to share my screen. I hope you can see the slides from there. Is it showing?
Not now. Yes.
Okay, do you see an agenda? Oops, sorry. Okay. So like Dr. Omar said, I was given the title, The Experience from the New World. I think it's more about just, like he said, a different part, the experience from a different part of the world. And I just added that I hope to provide a roadmap to becoming an occupational environmental medicine physician here in the US, where I've been. So I will just briefly touch on how occupational environmental medicine is defined, the main competencies for occupational environmental medicine physicians, the training pathways for obtaining certification in occupational and environmental medicine, the career opportunities, and using my just short occupational environmental medicine journey to highlight those different career opportunities and maybe touch also on benefits and challenges of being in this wonderful field. So occupational environmental medicine obviously is recognized as a board-certified specialty under the American Board of Preventive Medicine that focuses on diagnosis and treatment of work-related injuries and illnesses. occupational environmental medicine clinicians explore the impact of work on health. On health, and the field is critical in identifying and mitigating workplace hazards and reducing the societal burden of illness and injury. As an occupational physician, one of the main ways to know if you are on the right track and if you have a good capture of your field is to see if you do have some of the main competencies, which is ability to diagnose and treat occupational diseases and injuries, ability to identify health outcomes of environmental exposures, knowledge of worksite operations, toxic properties of materials, and the potential hazards and stressors of work processes, ability to determine an employee's physical and emotional fitness for work, ability to educate workers on health, wellness, and sanitation, proficiency in workers' compensation laws, local, state, and federal regulatory requirements. This is particularly important here in the US because it seems different states obviously have different laws and workers' compensation regulations. So if you happen to move from one state to the other, it will not be a completely different process, but you do have to start familiarizing yourself with the local state's laws and regulations in order to be able to practice and advocate for your patients or employees. Ability to organize and manage the delivery of health services and maintain, obviously, your role as a physician and maintain your patient confidentiality. Workers' compensation system is quite a complex system. And I think if we were asked as practicing doctors here in the US about what's probably the most challenging piece of our day-to-day job, it is obviously staying within the workers' compensation system and advocating for the patients through the system. It is there to help patients. It is also there to help employers. And the occupational physician plays a very pivotal role in how to make sure that you are, number one, abiding by your ethical standards towards the employee or towards the patient. At the same time, you're also making sure that the employer's rights are not violated. And at any time, we don't want to favor one side over the other. I think as physicians, we always have the default sense that we're always there for our patients. And in occupational medicine, advocacy for workers is just also very integral in how we interact within that system and try to deliver healthcare to these patients. But again, like I said, workers' compensation is a very integral and very challenging component of our day-to-day job. So how does one become an occupational physician? In the US, there's mainly 3 pathways for a person, for a doctor to become an occupational health doctor. The first one, I put the residency pathway, which is what I did. So, and I put there's probably a slight difference if you are an international medical graduate, as opposed to being a United States, a US graduate. The residency pathway mainly has 3 components. The doctor has to have at least 1 year of clinical US experience. Number 2, has to have or be able to obtain a master's of public health. And number 3, have a 3rd year of clinical training in occupational medicine. So that first year of US experience does not have to be, it can be anything. It can be internal medicine, it can be family medicine, emergency medicine. It has to be some clinical discipline. And add to it, so the requirements, if we do A plus B plus C, to be eligible to sit for the board in occupational medicine, you need to do 1 year minimum of, let's say, internal medicine, have to have a master's of public health, 1 year of occupational medicine, clinical and administrative experience, and then you're eligible to sit for the boards. The reason I say it's different if you're an international graduate versus a US graduate is the ability to obtain licensure in particular states. For us as people who went to medical school outside the US, it is typically required that you have a whole residency behind you to be eligible to be licensed. So in my case, for instance, I did a whole 3-year residency in family medicine, and that made me eligible to obtain certification in the state of Washington, where I did my occupational environmental medicine fellowship. So instead of having 1 year, I almost was required to have 3 years of clinical experience. And then you get enrolled into a training program, which most occupational environmental medicine fellowships are comprised of 2 years. And the 2 years are dedicated towards obtaining a master's of public health. The way our schedule was laid out, that first year of the fellowship, in the morning, we were students assigned or affiliated with the School of Public Health at the same university where we're doing our specialty training. And in the afternoon, we had the clinic and we had all the other clinical and administrative rotations for occupational medicine. In the second year, you become mainly more clinical and try to invest more in your clinical rotations. At the same time, do your thesis for the MPH. Before the end of your fellowship or towards the end, you defend your thesis for the Masters of Public Health. And then once you complete your rotations, now you're eligible to sit for the American Board of Preventive Medicine in the specialty of occupational medicine. So this is the standard pathway for anybody who wants to pursue official training and become an occupational medicine doctor that way. There's another pathway, which is called a complementary pathway. And this is typically for doctors who are already practicing in a different field. They could be primary care doctors, emergency doctors, they could be physical medicine rehab doctors who develop interest in becoming occupational medicine physicians. And so they still have to have an MPH. So they will have already fulfilled that year of clinical training through their specialty and because they've already been practicing, so that counts. And they become enrolled in the program, but they only do 2 years instead of 3. Sorry, they only need the 2 years out of the 3, which is to do the MPH and to do the clinical OCMED rotations. Now, some doctors also would have had an MPH from a different time, any time during their medical career, because the Masters of Public Health, as we all know, has different areas of interest. And so many people obtain MPH in different disciplines, and that will still count towards them becoming occupational doctors. And if they have the clinical experience at least 1 year and they have the MPH, they only need 1 year now to be eligible to sit for the Occupational Medicine Board. The special pathway is a different one where they also, if they have specialty in another preventive medicine specialty. So preventive medicine in the US comprises occupational medicine, aerospace medicine, undersea and hyperbaric medicine, medical health informatics, and toxicology. So those who are specialized or do have a specialty through the ABPM, they also can apply for an additional specialty in occupational medicine under the Board of Preventive Medicine. And most of the time, they will only need 1 year of specialty training because they would have had already the MPH and the clinical experience. So those are the 3 pathways. Some of the main challenges facing the quest to invite more people to become occupational physicians is, unfortunately, the residency programs are shrinking in numbers. This is mostly a funding issue because a lot, like I said, because of the requirement of the research and the MPH, those universities and programs depend on national and federal grants and funding. And some of these programs have not been able to secure the funding to maintain their training programs. I remember when I was a fellow, there was about 33 programs in the US, and I think they're down to maybe 26, 27 currently. But they're still programs. The certifying body for occupational medicine doctors is the American Board of Preventive Medicine. It used to be that occupational medicine was almost like a small subspecialty within ABPM, but last year, occupational environmental medicine became recognized as an isolated and an independent specialty, and not just a small subsection. So that's the certifying body. I want to just bring the difference that we all belong to the College of Occupational Environmental Medicine. It is not the certifying body. So to become certified in occupational medicine, that goes through American Board of Preventive Medicine. To have your college affiliation where people get their continued medical evaluation and you get to work with colleagues to advance the cause of occupational medicine. This is done through the American College of Occupational Environmental Medicine, or shortly known as ACOM. So this is a brief outline of the training pathway and how to become certified as an OCMED doctor. Where do people go after they graduate? So many different opportunities, so many different, I think I've heard Dr. Umar earlier mention, it's a very diverse field, and that is the beauty, I think, of occupational medicine, is that it indeed offers quite a large spectrum of work opportunities or career opportunities. So a lot of us, when we first graduated from the programs, we went into clinical occupational medicine, which is, I feel, is more, maybe it's a bit more unique to the structure in the US. I don't think it's the same process in other parts where we actually take care of patients in terms of their injury management and their illness management. So if we look at just a day in the life of an OCMED doctor, you go to just your regular clinic, just like any internal medicine and family medicine clinic. The difference is obviously you're seeing patients or employees who have been injured or acquired illnesses through their job. And you become what's called their PTP, or primary treating physician. You're there to diagnose their injury or illness, and you establish care. There are specific regulatory state forms. So our progress notes or clinical notes, they are actually medical legal reports that get submitted to the third-party administrators or the insurance companies that are the workers' comp insurance companies that are responsible for the cost of the medical care of that particular employee. In the same clinical practice, it's a nice hybrid of injury management. There's also occupational health surveillance. So different agencies, different categories of workers, namely, you could think of law enforcement, police officers, firefighters, correctional officers. Those have their annual occupational surveillance, and those also are put in your schedule as a different type of visit. One has to be, as an occupational doctor, you have to be familiar with the medical standards for these special groups of employees. So obviously law enforcement and other, what the so-called safety-sensitive positions across different disciplines, they have medical standards that they have to meet in order to stay working. And so the annual surveillance is mainly targeting that you assess their ability to continue working in their field. And if you identify any sort of ailment or disease that that renders them unable to continue working, you address that and then refer them to the necessary specialties. A lot of us in clinical practice, we also have certification as medical examiners for the Department of Transportation. This is a special certificate or a specialized certification that occupational medicine doctors are required to have in order to also clear commercial truck drivers. This is a very large sector of the practice of occupational physicians. This is a highly regulated group of employees. And as we all can imagine, truck drivers obviously are encountering hazardous work standards day in, day out, and their medical fitness to perform this job is quite crucial. So they have to have the occupational doctor. You cannot see and clear commercial drivers unless you are a medical examiner and you're listed in a national registry of examiners. Also becoming familiar with those medical standards is almost like a book in its own. And if you see you will see in the occupational health conferences, all the lectures or the sections about commercial driver license are almost, the rooms are full, people are sitting there. It's a very, it looks like an easy job, but it's such a challenging job because it is tied to evolving regulations and evolving medical science in order to how you certify. So conditions that are disqualifying for commercial drivers don't stay static. For instance, for the longest time, we were not able to qualify any diabetic driver who requires insulin for treatment. Within the last few years, this has changed, and there was a move to provide waivers for those drivers if they meet certain criteria that shows that their diabetes was well controlled and that they are able to safely perform their day-to-day job. So again, clinical practice, in my opinion, is a very rich, and I think I owe it a lot in terms of introducing me to the just the whole spectrum of occupational medicine. It keeps you on your toes because you're constantly having to dig those books and constantly having to review regulations. You're also having to look at the new medications that come because the workers, the employees will come and show you what they have, and you have to stay in touch with all those advances. So it's a very interesting and actually fun type. It has its own challenges, but it's a fun type of career pathway. Other opportunities are within academic institutions where you can choose to become an academic occupational medicine doctor. That can be in the setting. You could be, a lot of the graduates of residency programs get offered positions to stay along as faculty members and participate in the teaching and training of the new residents or fellows that come on board. That sometimes is very appealing if you are especially from the area where you trained. If you were not going to see, you're not committed to the region where you trained, then obviously people try to move different areas or different states and obtain their license and work there. But mainly academic institutions. With your MPH, most of the time you get an appointment. You can get an appointment through the School of Public Health. And you can also participate in teaching of MPH students. The MPH that is offered through most of the occupational medicine residency programs has an occupational environmental health science focus. So it kind of equips you to become an instructor or a professor to can teach if you like academic life and being a faculty. And at the same time, it's very nice to work with students and medical students, and a lot of people find a lot of reward in preparing future generations to go into occupational medicine. Research is the same. Typically, it's offered at academic institutions. And so oftentimes, if you stay along as a faculty member, you will be involved in research. There are positions that are mostly clinical, even within academic institutions. So if you're not very big on research, or you don't like research, or you just don't want to do research at that time, you can also consider academic but clinical type of appointments in your job. Another avenue that a lot of people go to is corporate medicine, which is becoming an occupational medicine physician for major corporations or organizations. And a lot of the senior colleagues that we've had have already come from such backgrounds. I think the history we know about training of occupational physicians in the US, the residency training programs are quote unquote newer compared to the past. So most of the pioneers of occupational medicine in the US have started as company doctors in different industries. So General Motors or Ford in Michigan, where they have the industry of automobile industry, oil and gas companies in Texas and other areas. And then so they always say that they grandfathered into occupational medicine, having assumed that company doctor role at some point in their life. And then as they moved along in their career, those pathways to become officially trained and qualified in occupational medicine became available, but they have been doing the work and the job already as occupational physicians for years and years before. Government agencies, obviously the highest government agency that is strongly affiliated with occupational safety is OSHA, which is the Occupational Safety and Health Administration. This is the regulatory body that oversees all workplaces in the US. They're the so-called workplace police because they are the ones tasked with auditing and evaluating the workplaces, making sure that they are compliant with safety standards, they are compliant with their safety training standards. They also have to access what's called an OSHA log, which is every company has to have a log or a record of their recordable injuries. And this OSHA log is used to, it's almost a surrogate of that company's safety record. There are certain criteria for an injury to be identified or acknowledged as a recordable injury. And so because there are injuries that are not recordable, those are the simpler injuries that we collectively refer to them as first aid injuries. They don't require much of treatment. They don't require any change in the employee's work status. And people just incur those injuries, but they're then released to work quickly. So OSHA is a very highly esteemed organization. It's also a highly respected and highly feared organization by employers because you don't want to be on the bad list of OSHA as an employer. You want your records to be as good as possible by investing in the health and safety of your employees. Another body that also works closely with OSHA is called NIOSH. So OSHA and NIOSH are the two entities that oversee occupational safety across the workforce in the United States. while OSHA is a regulatory body, NIOSH is the research and the science entity. So they work collectively. NIOSH conducts the research on hazards and the hazardous nature of jobs or chemicals, and they provide the research and the science that supports the regulations that OSHA will implement. They also issue what's called as RELs, or recommended exposure limits. And that's obviously the limits that are considered safe to work with for multiple chemicals and substances. And those are then OSHA takes those recommended levels and adopts what's called PELs instead of, which is permissible. And so between the two, they work very nicely to be constantly enforcing and bringing to the workforce regulations and recommendations that protect the health and safety of employees. Other opportunities lie in the so-called consulting services. This is mainly for more obviously seasoned and esteemed and experienced occupational doctors, where they can be hired by companies almost as a consultant to help with their environmental and occupational hazards and how to develop safety programs, how to invest in just the overall occupational safety for particular companies. And this is just coming recently from the Occupational Health Conference, kind of a pathway that you can have a full-time job as any of the other entities we just spoke about, and you can take a side hustle, like they call it, a side job as a consultant for other companies. So in terms of revenue generating, it can be a very lucrative addition to people who have the time and have the ability to do consulting, or some people are employed as full-time consultants anyway. And they also find a lot of fun and joy in that type of practice. Those are just the main ones, but there's truly a very wide range of jobs that occupational medicine provides. And the nice thing is unless you retire completely, and now I heard that retirement means that you have to retire 3 times before you actually retire in real life. So all the experienced doctors, and I think Dr. Umar, you may relate to that they retire from their first job, they fail the retirement because they cannot stay not working, and they go back and find another job. And then they fail the second time. Failing here means that they don't stay retired. They go back and get another job. And so most of the time, people don't retire easy. They go and do all these jobs. So a very nice trajectory on careers as an occupational medicine doctor. I put here just an outline, trying to put it together, all those different areas that people work with. In my occupational medicine journey, which is now about 19 years, I think I first heard of occupational medicine very early in my career as an intern in Khartoum. I was doing an orthopedic rotation at the military hospital in Durman. And this was a hospital that received all the injured soldiers from the war that was ravaging in South Sudan. This was 1995, I think, was when I was in that role. And I'm sure it may have been touched upon earlier, that the biggest gap that we have in occupational medicine is that it is not well introduced to medical students to start with. Nobody really knows about occupational medicine. And if I was a medical student and somebody told me you're going to become an occupational medicine doctor, I think that would have been just the most absurd thing I would have heard, because back in the University of Khartoum, when we were students, occupational medicine was literally a 1-week course And it seemed almost like history, the history of medicine or something. There was no life to that discipline. It spoke about pneumoconiosis, and honestly, the lectures were done at 3 p.m. when it's hot and we're tired, and we came from the hospitals and we dragged our feet to go just because we had to go. We did not see anything that was inviting. Now, you take that very short period of almost no training, and I found myself as an intern in the orthopedic department, and I got called with my registrar and consultant that we have a so-called disability clinic. And I did not know what that was, and I think it was the most challenging experience because I just did not have any training to prepare me to be in that role. And here you are stuck with very tragic injuries. Those were young people, young men in their 20s, maybe somewhere 18, 19. And I still remember they have amputated legs, they have amputated arms. They lost their whole livelihood and earning potential that early in life. And I still remember staring at my registrar, and I said, what is it exactly that we're going to do? Because I don't know what to do. And the quest for that, the purpose of that disability clinic was supposedly to evaluate those injured workers or injured soldiers and somehow estimate their loss and try to come up with a monetary sum or a number so they can get quote unquote reimbursed for their losses. It just seemed very bizarre that you could even put a number on somebody who early in life has lost every potential to have a decent living, to earn their life, and to work and navigate. A lot of them were supporters of their families. He was the biggest, he was the oldest son, he was the husband, he was the brother. It was just a very traumatic experience, I will say. I don't think even my registrar or even the consultants have had training in occupational disability or impairments. It was done very generically, I will say. But there was a system, and they will sign on a paper and they will give it a number, and that injured person will take that paper and go to the cashier or whatever, they get that money. And it was a one-time lump sum that's given, and then they're done. So very, very tragic in that way. And that stayed with me when I was doing family medicine residency in New York, maybe 8, 9 years later. And we started seeing those similar injuries, not necessarily as drastic, but people who were coming to claim their injuries and to get some monetary disability money because of their injuries. And then I connected with my program director and family medicine, and I said, so what is occupational medicine, and how do you guys do it, or what do you do for it? And surprisingly, what I came to know at that time, even in the US, and I think it may be also all over the world, training in occupational medicine, while it was an integral part of family medicine training, my program director showed me the curriculum at that time, which had a whole section that all family medicine residents have to have occupational medicine training as part of their curriculum. Yet nobody did it. And he flat out said, well, we know we have to do it, we just don't have anybody to do it. None of the faculty had any occupational medicine background, so obviously they could not provide training to the residents. And then as I found that you could do a fellowship of occupational medicine, and I came to him, he was actually my advisor, and I said, I want to go into occupational medicine. He had me present in my second year of residency, he had me present an introduction to occupational medicine to our whole residency program. And that was how I started that path towards occupational medicine. And then after I finished residency, I went into the occupational environmental medicine program at University of Washington, where I got the official training in occupational medicine. Once I finished, my first job coming off training was with an organization known as Kaiser Permanente, which is a large, probably the largest health HMO or managed care organization in the US. And they have a very robust program called Kaiser on the Job. And that is essentially their occupational medicine department. They are the largest employer of occupational medicine doctors. It mainly is a clinical role. So again, seeing patients the same way I described earlier, and get trained in doing what's called impairment rating. And again, I wish I had that training when I was that intern back in Khartoum, and could offer something at least more objective in terms of how you identify the injuries and how they impacted these young soldiers that we dealt with. So impairment rating is a very complex process, but there's a clear pathway to learn it. It goes through a book called AMA Guides for Impairment Rating, and it teaches you how to quantitatively and objectively evaluate an injury, its impact on the person's body, and then you submit that to the insurance and they handle the monetary values, because as doctors, you really don't have that access or knowledge. And so we do the medical piece and let them figure out the other logistics. I stayed at Kaiser for 2 years, and then I moved from one city to another. It was all within the state of California. So as I mentioned earlier, the challenge sometimes is learning laws and regulations as you move. So because I trained in the state of Washington, there was a whole set of laws and regulations. Coming to California, California is always a bit more challenging in terms of how they run their things. So again, their laws and regulations is something that I had to start learning in order to help advocate for my patients and my employees. Stayed at I've been in Sacramento now for 13 years, 14. And I had worked with Mercy Medical Group, another occupational medicine department. And then in 2013, I took a job as an occupational medicine consultant or specialist at the King Abdullah University of Science and Technology in Saudi Arabia. This was a new role because this was a new university, was built almost around the model of Aramco, which is the oldest, obviously, clinic or oldest department of occupational health in maybe the whole Middle East and Saudi Arabia. The role was more multidisciplinary, and that was the main attraction. As my personal interest at that time, I really wanted to move closer to Sudan, where my late mother, Allah yarhamha, was in Sudan, and I wanted to be closer, and also raising kids and getting them exposed to the culture and the religion. So at KAUST, or King Abdullah University, this was a graduate university for research in the Middle East and the Red Sea region. So there was oversight. I worked with a lot of different departments, industrial hygiene, environmental health and safety, and we were building those programs from scratch because they were not even present to oversee. There was the laboratory exposures, there was the musculoskeletal, the ergonomics of the heat illness. So again, it was a very nice role. And that's, I think, where I got introduced to Dr. Muhtasim. We met and we worked together when you were at King Abdulaziz, and you invited me, and we joined forces at that first conference for healthcare workers, occupational health safety, occupational health hazards in the healthcare worker population. So I stayed at King Abdullah University for 3 years before moving back to California. I actually spent 3 years again with my old group at Mercy Medical Group before taking on my current role in the University of California, Davis. The nice thing is that, like I said earlier in the career, you can change focus, you can change interest. So clinical practice, you like it, I like it, I keep it as part, but then you actually get trained in so many different facets of occupational medicine, and you start missing that, well, I don't do a lot of toxicology in this role, or I don't do a lot of population health in this role. The medical center occupational health is an area I was doing partially through my role in Mercy, but this role currently at University of California as the medical director of occupational employee health, I'm in charge of the occupational employee health of all the healthcare workers that work at the medical center of University of California here in Sacramento. And then with that, I joined I got appointed as a clinical instructor in the Department of Internal Medicine, and then as a volunteer faculty at the School of Public Health Sciences. So this is the overall journey that I have had. I think my last slide goes to just from my own, this is not necessarily reflective of any specific entity. These are just the benefits and challenges that face us or face anybody who wants to be an occupational physician in the US. Obviously, the greatest thing the greatest benefit is that it's a very rewarding and meaningful job to work with injured workers, to advocate, because even in the first world countries, employees face sometimes very egregious actions from their employers, or from just in general, systems sometimes fail the employees, especially if they have other underprivileged characteristics, being immigrants or undocumented. And it's actually nice, and it's a very rewarding role to be able to advocate and get these employees the care they need and the benefits they need. It's a diverse scope of work, as we have already touched on. The low burnout rate was actually not just a comment. This was a study that was made, and it identified occupational physicians as the number one specialty in terms of job satisfaction and low burnout rate. Physician burnout right now in the United States, and I'm sure it's all over as well, is almost like an epidemic or almost a pandemic. It's being recognized across all organizations. That's why a lot of the wellness committees in all of the organizations are focusing, because the medical profession, unfortunately, has become a very hazardous and a very stressful profession, and people are jumping ship, like they say. People are choosing to move away from medicine because of the challenges and the stress. COVID in itself created, I think we all have seen a change in our patient population, mental health, everything. It has just become very challenging to stay in practice. So we're lucky in occupational medicine. We have seen some of that similar trend, but still a very rewarding career. Work-life balance is a very major attraction, especially sometimes for mothers and female doctors who, for instance, are trying to balance life between having little kids and being able. So most occupational medicine jobs offer regular hours. You don't have to be on call. Even if you're on call, we carry beepers or a phone. They just call you for consult. You don't have to go into the hospital, and you have your weekends free and regular hours, which is very appealing. There is a high demand for occupational medicine doctors, as we are seeing through the curve and attrition rate of the generations that have been the sole occupational physicians. So there's a nice need and a nice attraction for jobs in occupational medicine, and give somebody a sense of job security that you should stay somewhat safe in terms of being able to find a job. And the jobs are well compensated depending on where you practice. They're very comparable to other specialties. I will say if you factor the workload and the money, it's a better balance than primary care, because primary care has the workload has become very daunting on primary care doctors. And again, that burnout is happening mostly in primary care specialties. The challenges, on the other hand, like I think I've touched on the laws and the regulations, because these are not very nice things to learn sometimes, and they're very challenging to know the laws. And obviously, there is a medical legal component. As the occupational physician, it's not unheard of that you can be deposed by lawyers for a particular case. The interesting fact about practice. Now, medical practice in the US, as everybody knows, is a very litigious environment. Patients are very used to suing doctors and suing this, and I will sue you for that. So luckily in occupational medicine, we have some of the lowest litigation rates against the occupational providers. There's a high litigation rate against employers and against insurances. So nevertheless, you're caught in that triangle, like I mentioned earlier, because the triangle that involves the doctor, the patient, the employee, and the employer or the insurance, they're entangled. So sometimes if your patient is represented by an attorney to help them navigate the care and get the care they need, and you've been providing care, and at some point that case goes to court, you can be deposed by the attorneys, both from the employer or from the patient, to as an expert witness. So those are stressful situations, even though this is not targeted at you as the provider, but still just being in that whole environment is highly stressful. Luckily, this is not a lot, and you don't have to do that, and you may never have to do it, hopefully. But you're always protected by your own malpractice and your legal team at the organization that you work. You would never be alone in any of those settings. Challenges of dealing with the workers' compensation system. This is because obviously the care for workers is subject to guidelines. And sometimes we differ as the clinician. So if I see someone and I examine them and their examination is screaming for a ruptured rotator cuff, I don't want to send them to physical therapy. I need that MRI right there because they may be a surgical case and there's an essence in moving their care quickly. And then I might find an obstacle because the insurance will say, well, wait a minute, it's not been per guideline 6 weeks and you haven't treated them conservatively and you can't get an MRI. So some of those nuances sometimes come in the practice and they can be not really fun. Another major challenge, and I think that applies also all across the world, because having worked in different organizations and different parts of the world, it was the same theme, that the role of occupational medicine is not well understood even by the employers you work for. They hire you on as the expert in occupational medicine, but they also may either not have ears for what you're bringing to the table and trying to advocate for, to change systems or processes or just how things are done, or it is not perceived as a very known or maybe not even a highly acclaimed specialty. So that sometimes creates its own frustrations, because you know that you can do more, you know you can do X or Y, but you're not getting the support you need. And that can be very frustrating for the doctors. And then the last challenge, as I mentioned earlier, was the number of training programs that unfortunately has been going down due to funding and other reasons. But the American College of Occupational Medicine, and they have a lot of task forces that are working on trying to improve the situation, trying to incorporate occupational medicine training in medical school curricula, and hopefully maintain and sustain the pipeline for these doctors. So that is all I had to say. I've just put the links for all the new doctors or the young doctors who are attending the session to see. They can go on the American Board of Preventive Medicine, familiarize yourself with the pathways of becoming an OCMED doctor, and then the American College for Occupational Medicine, because it's really a very resourceful website and can be of benefit. Thank you, and I'm sorry again for being late.
Thank you very much, Ines. Thank you so much. You know, Ines, I think about 25 minutes ago, I had people knocking, you know, on the door, and you know, I saying time, and I just could not get myself to stop you. Thank you so much. That really is a wonderful explanation, wonderful presentation. Thank you so much, and we will make it available for people who haven't managed to join. If you don't mind,
Of course.
Ines. Thank
Of
you
course.
so much, and sincere apologies, Larry. I think it's coming your dinner time now in Nottingham, and I know this was one of the excuses that my manager was pushing is Larry is waiting to go, but here you are. Larry, I have known Larry. I'm not going to say the years. We joined the same training. What do you call it? You know, the Oxford training program.
Rotation.
Larry was in Reading and I was in Slough, and we were both connected to Oxford Deanery during our training. It was one of the most tough training programs in occupational medicine, probably in the whole of the United Kingdom. You would remember that wonderful young lady who, in her last session, she said, "I don't want to go through this anymore," and she went back to be a GP after 4 years of training. So I have known Larry since those years. Larry is here wearing so many different hats, presenting to the Center of Occupational Environmental Health Africa. You know, I introduce him as a true African who's going to work with us to push occupational medicine in Africa. He is the president of the Society of Occupational Medicine, which is probably, you know, in the old world is the, you know, the chamber of occupational medicine for everyone. And I do encourage everyone to look at that. Most importantly for most of you, Larry is the chief examiner for the Faculty of Occupational Medicine at the Royal College of Physicians of Ireland. Before that, he was the chief examiner for the UK faculty. Larry is well known for you know, pushing the boundaries of occupational medicine in the UK and internationally. Thank you very much, Larry, for agreeing to be with us, and thank you for your patience to be the last speaker this evening. So the floor is yours, Larry.
Thank you, Omar, for that very good, kind introduction. And I don't mind going later. I think the discussions have been very rich and will be very rewarding to everyone who's been listening. And I do sympathize with you, as in and as expose about the US was very informative, and I was glued to listening to her as well. So thank you for that. What I will do is I will try and share my screen. I use multiple screens, so sometimes technology fails me. But if not, Hadia, would you? If I don't work, then please share on my behalf. So let's see. Yeah.
Larry, happy? Yeah, there it is.
Let's see if is the full screen that it tends to fail, but I'm not sure.
It
Are you
is.
getting my full screen or not?
We are.
Okay, brilliant. It's worked. Uh, um, as Uma mentioned, I'm Lanre Ogunyemi. I've been a consultant for a few donkey years now, and what I intend to do is talk about a little bit about my journey. I'm not going to say anything about the US, but I'll give a little bit of how occupational medicine training works in the UK and the Ireland, and also just describe a recent prospect we've had and my thoughts about commonalities. And Uma tasked me with the future, so I'm going to mention something about global considerations. Uh, um, First, I I'm Nigerian by background, and I trained in Nigeria. I did my medical school in Nigeria and house job, and then came into the UK following house job. So all my postgraduate medical education has been in the UK. The in my yearbook, if you look at it, it said I wanted to be an O&G consultant. That was because there was one of the professors in medical school that I absolutely admired. But by house job, I did O&G and I knew it was not for me. But I was still very interested in pursuing surgery. So after I did the usual PLAB in the UK, which is the exam international medical graduates have to do in order to practice within the UK, I pursued basic surgical training. And during basic surgical training, I kind of fell in love with ENT, which was what I did for quite a while. And whilst I was a registrar in ENT, I developed a medical problem that meant that I was not going to be able to operate for at least 2 years or more. And I was considering what next to do. I did something unusual for me at that time. I actually took the time to try and find out what my options were and looked into various specialties. And the more that I discovered about occupational medicine, the more it became attractive. At the time, I was thinking, well, I will do this for at least a couple of years. And, when I'm okay, then I might be able to go back to surgery. So I pursued occupational medicine, but when the time came, it was really not a question in terms of going back. So I stuck with occupational medicine, and as Omar said, we were trainees in the Oxford region. I was at Royal Berks training. I do remember Omar borrowing me a book on disability assessment medicine, which I cherished at the time because even though, as I said, we had tough training, I felt we were not as schooled with disability assessment, and Uma had some experience with disability assessment. And I think that was probably the first time that we talked a bit in depth. And his kindness then has clearly shown through with the number of people who have raised his sort of mentioned how well he has helped them in their careers since. So thank you, Uma. So at the time, after training in Royal Berks, I then was appointed a consultant there. But I always knew that one of the attractions for me to occupational medicine was the flexibility of being able to go independent. So I was an NHS consultant for a couple of years, and at the time I also had a part-time appointment with a big occupational company called Capita, uh, um, which gave me a soft landing into independent practice. So my company is called TOPHS Limited. It started mainly as a consultancy vehicle to provide services, the kind that Ina described earlier, and I did a variety of services. It's only over the past 4 years that we focused more on providing training as well. But I have always been interested in the participating in the larger occupational medicine community. As pointed out, the occupational medicine community is one that's particularly friendly and collegial, so it's easy to network with people. And I think one of the reasons that it's that way is because sometimes you're working in isolation, and your colleagues tend to recognize that. So you end up building these networks to support you through your work. So very early on, I was examining for the faculty. I think I was about 2010 that I started being an examiner. Before that, I had been the regional specialty advisor or deputy for the Nottingham region. And whilst I was in the NHS, I was the educational supervisor as well, and doing some lecturing for the University of Birmingham. Like Omar, I had also done the masters with the University of Manchester, but Birmingham was a lot more local to me when it came to having any teaching responsibilities. And the examining commitment progressed, and I eventually became the chief examiner. I think that was 2017 to 2022, the COVID years. Uh, um, the Society of Occupational Medicine have mainly been involved in regional activity initially. The society has a regional structure, and we have, I think, 11. I think it's now 13 regions within the UK, but at the time it was mainly 10 regions, and each region has, chair, secretary, and treasurer. And when I moved to Nottingham, I kind of did each regional position in turn, but kept involved in the society. And a few years back, I was actually, even years before that, every now and then you're asked whether you're interested in becoming president. But 3 years ago, I said, why not? It turned out that when I was asked this time around, even though we've not had an election for a long, long time. As a society, usually one person puts their hand up, and then if another person puts their hand up, they're kind of reserved for the next year. But after I was asked, I put my hand up, and somebody else put their hand up as well. So we had to have an election. Uh, I was very lucky and encouraged by the election, and got over 70% of the vote in that particular election, which was a resounding endorsement of my having put my hand up. I became the first Black president of the society. The society is going to be 90 years next year, so I feel as if there's a good mandate, and they need to kind of really, really help and encourage the uh, 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 people and diversity within occupational medicine during my tenure as the president of the society. I'm going to just talk a little bit about the society because I think it's also a useful resource for anyone who is considering occupational medicine. I'm a president from for the next 12 months. The society does provide a lot of member support. You can find information on the society if you Google Society of Occupational Medicine UK, but the website is very simple, is som.org.uk. We tend to provide a lot of support for our members. Each region, as I mentioned, tends to meet regularly. Here in the East Midlands, we meet every 2 months, and the meetings are typically educational activities as well as social activities. We do have special interest groups as well. For the special interest groups, it tends to be either focused on a subject matter that we want that people feel they need support of other subject matter experts in order to help improve their understanding of the subject, or it tends to be a group of members. So, for example, we have special interest groups on hand and vibration, noise-induced hearing loss, long COVID, and so on. And then we also have other special interest groups tackle that people who are, sort of new career starters, like the diploma in occupational medicine interest group, end of career people like retired member special interest group, and then things like allied health practitioner special interest group, and also groups for people who are perhaps interested in multi-professional working. There's several of these interest groups, so there are various ways to help ensure you have a good network and support if you're practicing within the UK. We also have an international section, a special interest group as well. We have a focus on making sure that the members have very good education and career support. And with regards to webinars, you will find that we do webinars maybe two, 3 times a week. So there's a huge, huge back library of webinars that anyone in occupational health wants to have a look at that you can explore. We do some regular conferences. The main conference we do is one combined with the Faculty of Occupational Medicine, and that is happening in the next couple of weeks in Belfast. It tends to be June every year, and we vary the location from region to region. Next year is going to be Brighton. I would encourage people, if you want to have a taste of occupational medicine, particularly the collegiality within the community, visit one of our conferences, and you will experience that. I must say that the collegiality is not unique to us. I've been in a couple of international conferences recently. I was in ICO Marrakesh as well as the ACOM in Orlando, and people are in occupational medicine are amazingly friendly. So you make a lot of new friends, and you get to meet people and you get to understand the breadth of the specialty. We do a leadership event as well. We have a mentoring pathway, and we have people can sign up to be mentors. The Yellow Journal, Occupational Medicine Journal, is our main journal. We have partnerships that for people in the UK can offer discounts on financial things such as indemnity and practice insurance. A part of the role that I've really enjoyed recently is the advocacy. This is where we're meeting with ministers, parliamentarians, and the influencers to try and push the occupational health agenda. I mean, the main thing in that the Society of Occupational Medicine is interested in is seeing universal access to occupational health. And we are also trying to improve the capacity, as in get more people into occupational health and improve the level of research within occupational health. Not just research about the work conditions, but also research about things like the value of occupational health, so that when we're talking with the powers that be, they understand what we're saying better and there's some evidence behind what we're saying. So the advocacy bit is very important. I think every occupational physician should try and learn some degree of advocacy and persuasion, because in wherever you're working, I've not come across any country that appears to have enough occupational physicians. We're just so few. So the more advocacy skills we have, the better. We also have quite a few international collaborations. We visit other people's conferences that they visit us, and we have joint webinars with, the Australian Society, the International Occupational Medicine Society, and so on. And as I said, we're trying to build on the research base. So these are all things that you can look to share in if you are able, or if you're willing to join the society within the UK. And this is open to international members as well, not just people within the UK. Now, I'm going to try and give a quick overview of UK occupational medicine training, and then I'll say a little bit about Irish training before going on to talk about some of my views. Um, I, I like to look at this first at what are the training endpoints. If you want to become a consultant, that is an accredited specialist on the Medical Council of the UK, the path is you have a couple of paths for that. If you wish to become a You can also choose to practice in occupational medicine without becoming a consultant. I'm going to pause and just check now. A bit late for me to check. Can I just check that my slides are indeed moving? Okay, yeah. The last talk I did, I had gotten nearly to the end and discovered that my slides were not moving at all. So, yeah, so you can also practice in occupational medicine. Yeah, thanks. Yeah, you can also practice in occupational medicine without being at the consultant level. And indeed, I was reading earlier that just like in the UK, in the US, a huge proportion of people in occupational medicine are not practicing at the consultant level. So, which is not surprising. In the UK, for example, we have maybe 1,600 members of the society and less than 700 consultants. So, and not everyone who practices in occupational medicine is actually a member of the society. So, there is a huge space for people to practice, even if you choose not to specialize or not to become an absolute specialist within occupational medicine. The other thing I like to mention as well is that nowadays there's a lot of scope for portfolio careers. You can do a little bit of occupational medicine and psychiatry, a little bit of occupational medicine and accident and emergency. So you can combine it with so many other things. Now, for the accredited specialists, the training endpoint tends to be you have to get the membership of the faculty alongside competencies that I will talk about in a moment. For non-consultants, you can often practice with various professional diplomas or sometimes with academic diplomas and higher qualifications. The difference is that with the professional diplomas, you often have some specific activities that may be written in law that says, okay, you need somebody who has a diploma in occupational medicine to be able to sign this pension form or to be able to carry out this type of activity as a minimum. Whereas with the others, it tends to be at the discretion of your employer and your own kind of persuasion about your skill level. So the occupational medicine training program within the UK, you have the kind of formal training route, which is very similar to what Dr. Butasi mentioned within Ireland as well. It's a 4-year program. In the UK, is run by the National School of Occupational Health, supported by our deaneries. And the way that works is that you have a combination of service as well as training. And the training structure is kind of overlooked by the National School with a curriculum that's been set by the Faculty of Occupational Medicine. The main people that provide trainees for us in the UK are the National Health Service, the military, as well as the industry. When we were in training, Omar was in industry, I was in the NHS. Since then, the industry numbers have dwindled substantially, and they're very few. The military has tended to preserve his numbers. Ideally, the best thing I think is normally to have a training job that allows you to rotate through NHS, industry, and other kind of services. You do find that some services, whether industry or NHS, will include provision of other services, which then allow you to get exposure to other types of industry. But one of the things I'd like to see within the UK is much more rotation from different types of industry. Aside from the formal training, you can also have informal training. By that, I mean you are the one that is actually gathering and motivating your own training program. And this is something that we tend to refer to as like the portfolio route or Caesar route. And that is becoming more attractive to people in industry because it's less space and often more flexible. The sort of structure that one needs to understand is the UK medical training. You have kind of 3 main sectors to it. First, after you're a newly qualified doctor, you have your foundation years, which used to be the sort of old style house officer training. And then you move to what used to be like a senior house officer training, and then finally to the registrar training. So foundation specialty and the higher specialty training. And this cuts across all specialties That's the way it's structured. You don't come into occupational medicine until you are at that higher specialty training level. And we tend to take people from ST3 to ST6 because it's a 4-year training program. There's some programs that are much longer that then go up to 9 years. And after that, if you've achieved all your competencies, passed all the exams, you become an accredited specialist and you get on the General Medical Council as an accredited specialist. This is another way of illustrating it. Again, those 3 sections: foundation year, your core training, which for some specialties can be run through training, and then you come to the blues, which are the higher specialty training, which includes occupational medicine here. So that's the general structure of UK medical training. For us in occupational medicine, we tend to come in at ST3 and then go into ST6. In practice, a lot of people in occupational medicine would have done other careers or other specialties before then deciding to do occupational medicine and coming in at ST3 here. So I mentioned that TOPHS does a diploma course. On our diploma course, we find psychiatrists, accident and emergency specialists, orthopedic surgeons, immunologists, people from all kinds of background who have decided that they want, they've had a taste of occupational medicine somehow, and they want to have maybe a better work-life balance, or just somewhere where they can actually listen to patients, because GPs tend to be increasingly pressured with regards to how much time they have. So we find people coming from all sorts of backgrounds into occupational medicine training. And as I mentioned before, there's a portfolio route, which you don't have to be in an approved position for formal training. You just gather evidence that you have met all the competencies which someone going through the approved training will have had. From what Dr. Musa mentioned earlier, he did something like this within Ireland, so that you had all the evidence to show that you had met all the competencies, and then you go through the CSER route to become registered as a specialist in occupational medicine. I won't go into this in detail, but in order to get here, you need to just demonstrate that you have the relevant qualifications and experience, and you have met all the competencies, that foundation competencies. Generally speaking, people who have been practicing in medicine for a while will have no problem demonstrating that they can come into higher surgical training, higher specialist training within occupational medicine. This is just to illustrate the way the Medical Council tries to look at our professional skills and training. Back in 2017, they kind of developed an onion layer type of demonstrating that you have good professional skills and learning outcomes. And the General Medical Council dictated that this should be applied to all the different specialties. So in occupational medicine, we had to then make sure that our competencies fitted into this kind of map, where at the core of our learning outcomes were professional values and behaviors, with a kind of expanding arena of professional knowledge. And the way we then adapted that was to produce a curriculum. This is talking about the UK, which focused on these professional capabilities, examples of that, how each professional capability was going to be assessed, and what those learning outcomes were. A copy of this can be found on the faculty website. Some of the professional capabilities are assessed through exams, some are assessed during training through regular appraisal type events that occur whilst you're a trainee. The summary of the occupational medicine professional capabilities and learning outcomes are this, a bit similar but in more detail than the one that Enas shared earlier. And we have examples of this in the curriculum published by the faculty. So someone who's going through the portfolio route rather than the supervised route will have to have a portfolio of evidence that demonstrates they are skilled in health promotion and illness prevention. They have examples to illustrate leadership and team working, and so on. Now, I'm just going to talk briefly on the next couple of slides about Ireland, it's very, very similar to the UK. It's rather than the learning outcome based training is much more competency based and curriculum based. What I really like about training in Ireland is they rotate every year. They move from place to place, so they get very good experience in terms of industry placement, which I would like to see more of within the UK. The LFM is sat in year 2 of their training and the MFM in year 3 of their training. That is similar as well to the UK, where you sit a part 1 and a part 2 in years 2 and 3. The part 1 is equivalent of the diploma and the LFM, and the part 2 is the MFM, similar to the Irish MFM. Um, the this is a better illustration of it. And while we're talking about the components of the exam, I've used MCQs as the kind of old term but really we've moved to single best answer questions. There's still multiple choice, but there's only one answer that's right, rather than so it's a subset of MCQs. So if you're doing the LFM, you'll be expected to sit an MCQ exam. You'll be expected to submit a portfolio of 5 cases that you have been involved in. At least one of them must be a workplace visit, and you'll be have to have a viva on this portfolio. And similarly, if you're doing the MFM, the portfolio number, increases to 10 portfolios to demonstrate your experience. You have an objective structured practical exam, which is a clinical exam testing various skills, as well as we get you to do a critical appraisal exam and a report writing paper. I'm going to skip through this, and this is an example of a suggestion, just a quick discussion that we had with one of the Middle Eastern countries about building capacity and training within the Middle East. The MSc we're thinking of was like the University of Manchester, which is still running, and which could be a way that people could develop a lot of occupational medicine knowledge, but there will still be that challenge of having, building the portfolio, which I think is best done under supervision by someone who knows what is expected in the MFM or MFMI. The Royal College of Physicians of Ireland also have an IHED diploma, which is a course that is wholly online, lasts about 27 weeks. It doesn't quite take you to the LFM level, but we think this is in gestation, that there will be a potential to do a preparation course that will then bridge the gap between that kind of IHED course and being able to sit the diploma or licentiate exams. My company is one of 5 that offers a faculty-approved diploma in occupational medicine course, and we have this type of structure. You can look it up online if you wish, and which then allows you to sit either the LFM exam or the diploma in occupational medicine exam. We kind of split our teaching into 2 weeks, the first week being a week of mainly the principles, and then the second week being a week of the practicals, and then there's a huge amount of self-study and portfolio preparation in between. But all these are mainly entry, sort of the first level of recognized qualification in occupational medicine, and then to become but it's that first level is actually good enough for you to practice within the UK and in Ireland, but you should be practicing in an area where there's some clinical governance to what you're doing. That is, you have a means where you can escalate problems that are beyond your skill level. And some people are comfortable just sitting there, particularly if you have if it's part of a portfolio of in your scope of practice. The next step then is actually getting onto the MFM, which can be either I'm going through a formal training or building your own portfolio under supervision. And I know that a number of the occupational health companies within the UK are preferring this kind of route, whereby they have somebody who is an educational supervisor employed within their company and then looks after their own prospective portfolio candidates. So this is a way of if you're in a country where there isn't a clear occupational medicine training route, this may be something to consider. and then trying to bring things together. What I will say is that when you're looking to uh, uh, um, uh, bring your training together wherever there is, wherever you are within the world. There's generally a training institution. The training institutions can be universities or academic institutions. Here in the UK, it's mainly the National School of Occupational Health. I know that in some other places it will be mainly focused in universities. Then there will be a structured curriculum that you need to walk through, and then regulations and guidelines that govern how you become a specialist within the relevant governing body within that country. And I would urge that anyone who is looking to try to promote specialization within their country, try to break these things down and see how each one of these steps can be achieved. I've always been told that one of some of the prime movers for occupational health from the employer perspective is if they're compelled by the law to try and find occupational health, or if they find that there's a net saving, there's some economic benefits of occupational health, or just if they are caring for their employees. And that's a framework that I tend to have as well whenever I'm talking about occupational health to new companies. There is also a framework to think about what you're getting from your own practice as well. Sometimes you have to think about, okay, well, what am I offering in terms of benefits to my customers, and whether it's the care motivation or it's the money motivation. But those are some thoughts, and that will help you in terms of which level you actually settle for within occupational medicine. If you're going to be doing a lot of legally challenging work, then you really want to be an accredited specialist. Uh, um, the other thing I thought of was that we all have different models and different paths to specialization in different countries, and there's some fundamentals that cut across all the various specialties. There's some transferable skills for that if you're working within the UK will be applicable whether you're working in the US or whether you're working in Chile or whether you're working in Africa. But in each region, there are also some things that tend to be very, very specific and which you need to learn about. So as Umar pointed out right at the start, practicing in Africa is very different. You need to know a lot about general medicine. You need to know a lot more about when you need to switch to being a treating physician versus just being a pure occupational physician, which is the tendency within the UK. So, but I foresee that there could be a matrix whereby some of these competencies are very well identified, and then you can then look at, okay, this, and that within the UK is transferable to this part of the US, is transferable to this part of the Middle East, or transferable to this part of Africa. And within that matrix, you can then try and develop what gaps there might be that then need to be looked at if you want to then practice in a different geographical environment. Aside from that, there are challenges that occupational medicine keeps developing, and we have to be thinking of, what does emerging technology bring? What are the new specialisms that are occurring? But I do think that part of us being responsible, I think that we need to focus on a lot of the leadership training within occupational medicine so that people can recognize its opportunities a lot easily and also have the skills to be able to take advantage of that. So that's my very, very swift canter through a vision of the future for occupational health. And I will rest there. And thank you all for your attention. Thank you, Omar, for the opportunity, and thank you to all the previous speakers for making my job easier. I'm
Thank
happy
you.
to discuss.
Thank you very, very much, Landry. That was absolutely brilliant. And, as we suggested, I think the title of the talk sums it up really. Thank you very, very much indeed. I think between you and Inas, you have really, just made it very clear for people wherever they are, the actual routes they can take into specialty. I know we have gone over time by almost 45 minutes. I hope, I certainly have enjoyed this very, very, very much. I'm just going to say a few, have we got any questions, Hadir? Have we got any questions that you want to ask the speakers before I close? I think we've gone 45 minutes over.
There were some questions to Dr. Inas that I think she answered the questions, and there is another group of questions. I don't know, because my connection went off, so probably Samir, Dania.
Any relation between occupational and disaster medicine?
Any relation between occupational and disaster medicine? We'll get Inas to answer this from the New World experience.
She's on mute.
Inas,
Sorry, Inas, you're on mute.
Inas, you're mute.
Sorry. The only time I actually had been involved in disaster management or disaster medicine was somewhat within the time when I was in Saudi Arabia, and that was because you had all these departments working together, and the occupational health was considered as an important cornerstone of the whole disaster management plan of the organization. In terms of, if you're asking about in terms of the training, definitely there's not such, but no such training incorporated directly. We do get involved in mostly hazardous substance training and dealing with catastrophes like hazardous spills or chemical spills. There's a big move now in the US, at least also in health organizations, under a regulation called USP 800, which deals with hazardous drugs and exposures to those drugs, but also mostly from an occupational perspective on a day-to-day basis. Again, back in Saudi, that was part because we were called together with fire department, with EHS and industrial hygiene to be, we had to develop and be part of the development of disaster management. But that's the extent that I, at least in my experience, have gone through. Maybe others have had different.
Thank you very much. Larry, you want to respond to this?
I very much agree with that analysis. In the UK as well, we do not have a specific module on disaster medicine or anything like that. There's a bit of a fleeting reference to it. And I guess the people who are maybe CMOs in organizations that might need to respond to disaster medicines, they will then try to learn more, if that makes sense, about it. But in terms of general curriculum, we tend not to focus that much on it. Having said that, I've seen some nasty questions several years back in the FOM that did ask about a disaster medicine question, but it never resurfaced whilst I was chief examiner. If I may go on to just another quick question that I've seen on the chat. There's a question about whether the LFOM is recognized by the GMC for practicing in the UK. That's a very good question, because the LFOM is recognized in Ireland for practicing. So if you do the LFOM exam from outside, it will allow you to get registration within Ireland, but it's not the case for the UK. The UK does not recognize even the diploma in occupational medicine within the UK is not enough for you to get on the register. You have to either do PLAB in order to get on the sort of ordinary register, or go the whole way and become a specialist in order to get on the specialist register. So hopefully that helps.
Thank you very much, Landy. Thank you. Are there any questions, Simon?
There's one more question. Worker compensation.
Work compensation for
Worker compensation insurance?
I think, and just I want to comment about the disasters. The causality, all the time they look for the causality, the relationship between the incidents happens and the causality is the material which they are creating the risk. This is sometimes they're asking the occupation health to look for that.
Okay, I could take the question on the workers' compensation. I think this was Dr. Tijani. It said worker compensation insurance. I'm not sure if the question is what it is or how it is involved, but essentially, you can think of it as the health insurance for the occupational injuries and illnesses. There are different models. There are organizations or employers who have they are self-insured. Currently, my employer, University of California, for instance, they use a third-party administrator, which is called Sedgwick, which is a workers' compensation insurance. They pay a premium as an employer. The whole rationale of the concept of workers' compensation, when you look at the history of how it was developed, this was almost kind of a settlement agreement between employers and employees. Because in the past, the projection was if when employees get injured or workers get injured, they can essentially be, the employer can be liable for the management of that injury, and it can be tremendous cost with no limits. And at the same time, it does not absolve the employer from being potentially legally pursued by their employees. So it was almost like a deal that was struck between employers and employees that the employees would waive generally their right to some of their rights to pursue legal adverse action against their employers. However, the employer has to provide workers' compensation insurance, which mainly covers the cost of their medical care and also covers their wages for any time off or time loss that they incur. And so basically, this is what the workers' compensation insurance. So when we see the patients, they come in the let's say I see a new injury, they file a claim, and the claim gets sent. They do an incident report. They report to their supervisor. Supervisor sends them to the clinic to be evaluated, and also sends that report to the workers' compensation insurance. So they open a claim. In the US, once you file a claim, they assign a sum of about $10,000 worth to cover medical expenses for that injury. That does not mean necessarily that employer is accepting liability still. In some cases, they can still put those claims on delay, but the point is that medical care should not be delayed or withheld from the employee. They continue treating. Some cases obviously are going to go beyond the 10,000, especially surgical cases or treatments that will go for longer time, depending on the nature of the injury and how complex that is. But that is obviously the payer for the cost of care. And then if that person ends up being off work, they do pay, they become their payer for their wages. They don't pay the whole salary. So if somebody is injured on the job, when they
She went out, I think, Ines.
I guess her internet connection is not stable.
To do LFOM, is experience in OM required, or GP experience is enough?
Thank you. That's Dr. Saba's question. The GPX, normally it's intended for GPs, if that makes sense. But when you're preparing for it, you're expected to try and gain some occupational medicine experience, which can be just sitting in a clinic or having attended a course. and your portfolio, you need to submit a portfolio in which can be from your GP cases, but looking at it through the lens of occupational medicine. But you do not have to have had training in occupational medicine.
Okay. And if you complete ID diploma RCPI, it allows me to work in Ireland.
Now that one I do not know. I suspect not, but yeah, you see, Oma knows.
Yeah.
Yeah, no.
Am I? No, I'm not mute. No, I hit diploma is you know, as you know, Larry was saying, this is an academic qualification. It is just like if you almost do the MSc degree on occupational medicine from the University of Manchester, that is not going to get you registered to work in Ireland or the UK. These are academic degrees that you actually use them to gain most of the you know the bodies that certified doctors would like professional qualifications. The MFOM, the LFOM, diplomas in some places, but usually the MFOM, the LFOM, or obviously in the new world, as Ines knows, is completely completely different. But I think the very important thing here is you use, these academic qualifications if you are down south to gain more knowledge to get the actual professional qualifications, the LFOM or the MFOM. And I think Lan's presentation was very, very, very clear on this.
Yes, Dr. Omar, can I add something? Actually, the diploma preparing you, the ground is to go to the other qualification like licensing. Instead to ask you the experience before, how many years you worked, in the occupational medicine before to attend any examination. And this is diploma, they will give you the right way to go for licensure.
Right, I think we've gone a few more questions. Sorry.
There are a few more questions, and they seem to be for me, so I'm happy to take them. If you, okay. With regards to Dr. El Sharif about the 2 years of relevant previous experience, will the portfolio residency be only 2 years? The answer to that is that no, because it depends on your competency.
Yeah.
So there's no sort of set time scale for how long it will take you to do the portfolio, depending on your previous experience. So you will have to submit your, look at your portfolio, check it against a matrix of all the competences, and then it depends on how much time it then takes you to complete whatever the shortfall is rather than the time. Then the next question was why the MFOM examinations are once a year, not 4 times a year. It's a numbers game, the exams, because the exams are expensive. So the more numbers that you have, then the more frequency you can have the exams. Currently, the Irish exams are once a year. The UK ones, when Uma and I were doing it, was twice a year. It's then dropped to once a year, then became every 8 months. So it depends on the numbers that tells you how you're going to do it. And then the final question was, let me see, Dr. Hamid. Yes, I'm finding supervision within UAE. I'm glad Dr. Hashem was on the call earlier. So, and she put her email in the chat. So you're probably best advised to just get in touch with her. She's also on the exam board for the Irish faculty, so she'll be very keen to help support the LFM and MFM exams. Thank you.
Thank you very, very much, Larni. Ines, we just trying to reconnect Ines, and then I'll do a few closing remarks.
I'm here. I got disconnected in it.
All right.
There. Yeah, sorry, you dropped off the call.
Yeah, and I went to the stars. You see, I went to the moon.
Fantastic.
They are.
Availing myself for any questions if somebody has a question. That's okay. I think I got interrupted when I was doing, but I think we may have answered the question about workers' compensation.
Yes, yeah. Thank you very much indeed. Well, thank you all very much. I'm really, really grateful for our panelists, all of them. You probably have noticed that, in occupational medicine, we tend to be like a true family. Honestly, Hadir, Muhammad, Mu'tasim, Inas, Landry, they really are. I mean, I was an orthopedic surgeon for 20 years. I never had similar, either personal or professional relationships within the specialty like what I have in occupational medicine. Landry, a couple of weeks ago, introduced me to a doctor from Tanzania who is a senior, doctor within the WHO. We exchanged few emails. She is doing a keynote speech for us in a month's time on a webinar. And really, this is one of the beauty of this specialty. I think, and I sincerely hope, the personal experiences of our panelists today would have inspired every single person who is on this call to consider occupational health as a career. This is not an easy, journey. It is tough. You can, from the questions you can see. But as I said at the start of this webinar, we really are here to support not just the Center for Occupational Environmental Health Africa, but every single person who is on this webinar today. So this is the second important thing. The experiences of our panelists today are different, but they really are quite similar. They all came to occupational medicine from different perspectives, different specialties, and I really hope, as every one of you would have seen, how diverse, how rich this specialty is. We haven't had the chance to speak about it in more details, but there is much more to it. Every single one of our panelists would have spoken about it in much more details. Another announcement, there was a question about, support in the Middle East. Last week, I with Dr. Aisha and two colleagues here who have got private occupational health centers, both of them, they said they are 100% happy to support people with their training. We can put this on the, on our website. Dr. Aisha is here, as Lara said. I am mostly in and out of the Middle East as well, and we're happy to support everyone in the Middle East. We are currently talking, I think my good colleague Nimbu is on the call. Nimbu is an occupational health physician from Kenya. And we were talking about, an academic degree in Kenya. Before the war in Sudan, we were about to establish an MSc degree with faculty from most of the people who are here, and with collaboration with the Irish faculty and the University of Manchester, for people to have, local training. So we're going to consider this. We're talking to colleagues in Saudi Arabia and in Qatar about academic qualifications in occupational medicine. So keep looking at our website. The news will be there. I sincerely hope you all had the email from Kuwait. Keep emailing Kuwait. The one final thing is any one of you who really wants to embark on training for occupational medicine, we will support them. We will support you individually or as a group. If you are in a country or if you are an individual, do get in touch and we'll be more than happy to support you. Thank you all very, very much. And a very special thank you to our colleagues. And I'm really, really sorry. I think I would have a really difficult time with Hadir and colleagues here. We've gone over 1 hour, 1 hour over our time. But I think it has been a wonderful experience. Thank you all very, very much. And I hope you enjoy the rest of your weekend. Thank you.
Someone's asking.
Thank you. Bye.
Bye.
Thank you.
Just follow the Samira sent me, someone asked, when is the next session? We've got another webinar in a month's time on the 6th of July on the health of the healthcare workers. But, please do get in touch and we, if anyone wants a special, advice or training, we'll be more than happy to provide that. Thank you all very much. Thank you.
Bye-bye.
Thank
Yeah,
you.
bye.
Bye-bye. Bye.